How's it going, guys? We have a medium difficulty question for Gastro, step 1. Before we get started, please subscribe to my channel. Really appreciate it. Give you a like, really appreciate it. Find me on Instagram, Mehlmanmedical, Mehlmanmedical, links down below for me on Telegram, links to the Telegram group and channel down below. Now start the clip. 17-year-old boy, he's got a 3-month history of intermittent blood in the stool. Past medical history unremarkable. There's no history of travel. Vitals within normal limits. Question just wants to know what's most likely to develop in this patient. So you can see here this image. A lot of you have no idea what you're looking at. This is a granuloma, okay? Now, a granuloma is going to be activated macrophages that fuse together to form multinucleated giant cell collection. Okay, so this large circular lesion here, this is the granuloma clearly, and this is a result of macrophages that have fused together. And then you see all these these are nuclei, these little structures within. It's a multinucleated giant cell collection, as I just fucking said. Okay, so this is a granuloma. That's a pass level image right there, but holy shit, now we've got answer choices going on and more complexity. So let's just hop to the answer choice here. Choice A, actually, I'll just come right out of the gates. You need to know that the combination of a GI problem, so blood in the stool plus granuloma, equals Crohn disease. Okay, so non-caseating granulomas are seen in the GI tract in Crohn disease. Okay, if you look in the literature, they can actually show up in other organs. You can literally get non-caseating granulomas in the kidneys in Crohn. I'm not kidding, okay? But you need to know that in the GI tract on histo, that non-caseating granuloma is exceedingly high yield for Crohn disease. So let's hop to the other answer choice here, or just the start of the answer choice here. Choice A, hypercalcemia, wrong fucking answer. Now, I threw this in here as a distractor because obviously sarcoidosis, unrelated, we do get non-caseating granulomas, but you have to know you get hypercalcemia, right? So in sarcoidosis, classically African-American woman, 20s to 40s, and she's going to have non-caseating granulomas in the lungs classically that are going to secrete 1-alpha hydroxylase, converts inactive 25D3 into active 125D3. The latter goes to the small bowel, increases calcium absorption. We get hypercalcemia that way. Okay, I've made many clips on this stuff. In this case, wrong fucking answer. Choice B, iron overload, wrong fucking answer. First to primary hemochromatosis. Talk about GI related stuff because the mechanism, autosomal recessive HFE gene chromosome 6, the mechanism is going to be increased intestinal iron absorption. They want you to know that. So the pathophys for hemochromatosis, if I were to ask students, I'm like, well, how do you get iron overload though? What's actually happening? They're like, actually, you know what? I have no fucking idea. The answer is the intestines are unable to, the duodenum notably, because that's where we absorb iron. The duodenum is unable to shut off / temper the absorption of iron. So we absorb too much iron. So that's going to be primary hemochromatosis. Long discussion, bronze diabetes, hyperpigmentation of the skin, increased glucose levels because of iron deposition in the tail of the pancreas. You got other findings like infertility, cardiomyopathy, pseudogout, okay, arthritis. Wrong fucking answer. Choice C, primary biliary cirrhosis, wrong fucking answer. Now, primary sclerosing cholangitis, you can get an IBD. It's not limited to ulcerative colitis. You can absolutely get primary sclerosing cholangitis in Crohn. You can, but this is different. This is primary biliary cirrhosis, which is going to be a woman 20s to 50s who has high cholesterol, increased AST, ALT, ALP, and direct bilirubin. So generalized pruritus, high cholesterol. They can tell you there's a stone in the gallbladder. That'll confuse some students. Well, it's just from the high cholesterol levels. And they'll tell you that there's history of autoimmune disease in the family. They'll say her brother has rheumatoid arthritis or she has vitiligo. And you can give ursodeoxycholic acid, aka ursodiol, which is going to decrease cholesterol secretion into bile. Wrong fucking answer. Choice D, psoriasis, correct answer. So you say, well, how the hell does that relate to Crohn disease? I'll tell you, very easy. It's going to be HLA-B27 constellation, PAIR, pair. So psoriasis, right? So psoriasis or psoriatic arthritis. Ankylosing spondylitis could be lower back pain. I could have made that as the answer. Like I said, he's most likely to develop lower back pain. That's worse in the morning. It gets better throughout the day. Sacroiliitis. Okay, so ankylosing spondylitis is a severe form of sacroiliitis. I is IBD. Okay, so Crohn, UC. R is reactive arthritis, formerly known as Reiter syndrome. So it's going to be classically a chlamydial urethritis plus polyarthritis plus red eyes. conjunctivitis, episcleritis, etc. So that's the simple version of it. PAIR. Okay, so HLA-B27 constellation. So if you get a vignette, for instance, on USMLE where they give you psoriasis, they give you lesions on the extensors. They like to give it to you on the lip, on the forehead sometimes. So you get a psoriatic lesion. They say, what's this patient most likely to develop? The answer could be blood in the stool from Crohn disease or UC. Okay, so you need to be aware of those constellations. Or if someone has psoriatic arthritis or psoriasis and they have lower back pain, you need to think, is that sacroiliitis? Is that ankylosing spondylitis, especially if a male 20s to 40s? Okay, long discussion. There are exceptions sometimes. There's even a pediatrics question on 2CK where it's like an 8-year-old with ankylosing spondylitis, but we're talking 19 out of 20 times. It's going to be a male 20s to 40s. Okay, so HLA-B27, let's just hop to the finalist choice. Pyoderma gangrenosum, wrong fucking answer. So this is classically a lesion on the arm, necrotic ulcer. Okay, they'll say there's ulcer on the arm with necrotic debris. I've only seen one question on it. This is classically an extraintestinal manifestation of ulcerative colitis. Now, if we want to be real fucking pedantic right now and Google this type of thing and say, is it possible to develop in Crohn disease? It's possible. It's not classically associated. It's UC, as I just said. But overall, when we say, even if this could be associated in theory, is it more likely than psoriasis? The answer is no, because of PAIR, HLA-B27 constellation. Important for USMLE. You know the deal. I'm going to make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.